Dr. Fiona Tuhebwe, and welcome to the WHO Afro media briefing, which is taking place in collaboration with the APO group. And as always, we start with our housekeeping. If you want to choose a language of preference, please go to the globe on the right bottom side of your Zoom application and choose your language of preference. That is either French or English. At the end of our panelists' talks, we shall have you ask your questions. Please let us know if you want to go live. We'll give you that opportunity. But if you do not want to go live, there is a Q&A function at the bottom of the application. Please also go ahead and use this function. Right now, I would like to introduce our Regional Director, who is always with us, joining us from Brazzaville, Dr. Mashidiso Moweti, the WHO Regional Director for Africa, and I will let Dr. Moweti introduce our other panelists.
Yes, thank you, Fiona. Good morning and good afternoon to everyone joining us for this press conference. Bonjour à tout le monde. So we're going to be talking about how African countries are preparing for a resurgence of COVID-19, which we hope will not come, and to update on the vaccine rollout. I'm very pleased to welcome for this conversation Mr. Thabani Maphosa, who's the Managing Director of Country Programs at Gavi, the Vaccine Alliance. Welcome, Thabani, to talk with us about the work of the COVAX facility. In African countries, there have now been almost 4.6 million COVID cases and 123,000 people have sadly died. Like the rest of the world, we're observing with great concern the heartbreaking situation in India. Here on the African continent, there is a potential for a surge in cases. South Africa has just reported 2,000 cases overnight, which is an increase of several hundred over the day before, and around 10 other countries are reporting an upward trend. With the start of winter in Southern Africa, we may well see further increases in the sub-region. And in countries such as Botswana and Ethiopia, intensive care capacities are already being pushed to their limits. Part of what's driving these situations appears to be new variants of the virus. As WHO, we are supporting countries to strengthen sequencing capacities to detect these mutations. So far, 42 African countries have reported more than 14,000 sequences. Variants B117 and B1351 have respectively been reported in 20 and 23 countries. And the variant of interest B1617, which was first detected in India, has now been reported in Uganda and in Kenya. With delays and shortages of vaccine supplies, African countries are slipping further behind the rest of the world in the COVID-19 vaccine rollout, now accounting for only 1% of the vaccines administered worldwide, down from 2% a few weeks ago. While shipments of COVID-19 vaccines have temporarily ground to a halt, or at least slowed down, African countries also need to step up and do their part. Only around half of the 37 million doses shipped to the continent have been administered so far. We need to get the available vaccines into people's arms fast. This requires investments in delivery capacities to mobilize the people and the resources needed to roll out these campaigns in every province, including partnering with the private sector where it's feasible. I'd like to add my voice in praising the United States' decision to support a temporary waiver on patent protections for COVID-19 vaccines and treatments, which could mark a game changer for Africa, unlocking millions more doses and saving countless more lives. For local production to really take off, investments will be needed in technology transfer, capacity building, and quality assurance backed by strong regulatory systems and private sector partnerships. In the coming months, the supply shortages mean there is a risk that the timeliness of doses will be suboptimal. To protect people from severe disease and death, we recommend that countries prioritize the first dose for as many high-risk people as possible in the shortest amount of time. The current constraints can be addressed quickly if countries with surplus supplies share their doses with those in need. We welcome the pledges by several high-income countries to donate doses. We hope that the timelines for these donations can be brought forward and actioned as soon as possible to prevent severe illness and save lives. With new variants circulating, low vaccination levels, population fatigue in adhering to preventive measures, and easing of restrictions, the conditions are present for a resurgence. What's happening in India must not happen here. If we prepare now, we will not pay the price later. As WHO, we're supporting countries to heighten preparedness activities. Of great concern is the management of severe and critical COVID-19 patients. Although capacities have improved over the past year, there are still shortages of oxygen supplies. Whereas most high-income countries globally have at least 2 intensive care beds per 100,000 people, only 9 countries in the African region have this many. We urge partners and countries to work together to rapidly scale up clinical and intensive care capacities. This will have benefits for COVID-19 and other life-threatening conditions. I commend countries such as Eswatini for pre-positioning resources at the district level and expanding training of health workers, and South Africa for reviewing resurgence plans down to the district level. I urge all African countries to take similar steps now so that we are better prepared in the event of an epidemic surge. Again, thank you for joining us and looking very much forward to our discussion.
Thank you very much, Dr. Moeti. Mr. Tabani Maposa, the media is awash with the global supply shortage of the COVID-19 vaccines. Could you tell us about COVAX's work to address the current supply issues in the African region?
Thank you, Dr. Tuwebe. Thank you, Dr. Moeti, and thank you for the invitation. As of today, COVAX has successfully delivered over 18 million doses of vaccines to 41 countries across the continent. Almost 40 million doses for lower and middle-income countries worldwide. Our system is working, however, not as fast enough due to the devastating waves that our brothers and sisters in India are experiencing. There is a delay in the delivery of Covishield. Vaccines are not coming as fast as we would have wanted them to at this particular point. To navigate this delay, our first priority is to help countries that have already received a first delivery to receive another set of doses so that they can administer the second dose. WHO has issued guidance to all COVAX participants to help them prepare accordingly. The WHO and UNICEF country offices are also providing tailored expertise support to countries that need this guidance. And I can tell you that those countries that have been hit by delays will be a priority for catch-up once supplies resume. We are taking a number of measures to get deliveries flowing again. Dr. Adwebe, you asked me the question in terms of what are we doing right now. We are in close contact with the Serum Institute of India, who have reassured us that while they will prioritize supplies to India, the COVAX facility is next in line. We are also urgently appealing to countries that have vaccines to share their share with COVAX. France has already responded to this call with vaccines that went out to Mauritania in the week that we are just closing. Sweden has announced it will donate 1 million doses to COVAX. I would like to thank these and other countries that have said they will donate and urge all those that have not yet done so to follow suit. It has always been a COVAX plan to diversify its portfolio. This week, we demonstrated very solid progress with an announcement of a deal with Moderna for 500 million doses. Today, in a few hours' time, we will make a further announcement that will again grow our portfolio considerably. We have also been aggressively fundraising for COVID, for COVAX vaccines. The advanced market commitment, which supplies most of the vaccines to Africa, is our innovative finance mechanism to provide donor-funded doses for 92 lower-income countries. To date, we have raised over $6.5 billion from our donors, and we are seeking a further $1.7 billion in order to secure 1.8 billion doses of vaccines. This will enable the AMC to protect nearly 30%, or half of the adult populations in AMC 91 countries. All of these initiatives will soon have a big impact in the region. We are telling our donors and our manufacturers supplies need to come fast and soon so that COVAX can deliver. It is only by working together that we will end this pandemic. But it is also important, as Dr. Moeti pointed out, for those vaccines that have been delivered, progress must be shown in terms of getting them to the arms of the patients. Thank you for this invitation, and I thank you for your patience and looking forward to answering your questions.
Thank you very much, Mr. Tabani, and indeed there's a lot of hope from what you're telling us. So, and now it's time, now that we've heard from our panelists, it's time for you, our dear listeners, journalists, to ask your question. Again, we shall give you an opportunity to go live, but I see so many hands that are up. Please also use the question and answer function in the Zoom application. But also remember that we will need you to provide your name and the news organization that you represent on this medium. Also, we have on hand Dr. Nsenga Ngoi, the Program Manager, Emergency Responses, and Dr. Richard Mihigo, the Coordinator for Immunization and Vaccine Development Program here in WHO Regional Office for Africa. So right now, I'll give an opportunity to you, Gabriel, from Wall Street Journal, to go live and answer your question. And ask your question.
Can you hear me?
Yes.
Okay, great. I have a couple of questions. First of all, they're all for Gavi. What is the overall shortfall of vaccine doses in the coming months due to the India export ban? And then you said you're looking for additional manufacturers outside the portfolio you have at the moment. What continents are you looking at? And would a TRIPS waiver at the WTO bring any, would it help with these immediate supply issues that you're facing? Thank you.
Thank you for that question. I think in terms of the manufacturers that we are talking to, you will be very much aware that we've been in discussions with Johnson & Johnson, and that one has progressed very well. But we are also engaging with China and Russia as well. So I think we have always said that any vaccines that have been pre-qualified and provided evidence to WHO will be considered by COVAX. But we are doing much more than that by making sure that we engage in conversations ahead of time while we wait for the appropriate data that needs to be presented to WHO for decision making before we then firm up in terms of moving forward. The waiver is extremely welcome. It opens. I think, as Dr. Moeti said, it is a game changer. It was one piece that was standing in the way of increasing production capacity as much as is possible. But as we have always said, it is one necessary step as part of a suite of solutions. We need much more than that. In terms of the shortfall that we're looking at, India had scheduled to give us something for April and May, and for those months, we are clear that we will not be able to get our supplies. And yeah, so that is the gap that we're dealing with.
Well, can you put a number on that gap? And also just to clarify, my question was not with sort of the developers of the vaccine, but actual companies that might still be available for getting licenses to manufacture in addition to the existing manufacturing capacity. Where are these companies that, you know, either have production lines ready to go or where production lines could quickly be built up? Thank you.
Sure, no, thanks. I think those conversations are still very nascent. So I would say that, you know, we are looking at Africa because Africa has, through the AU recently, been having a significant drive on vaccine production, but they are still very nascent, and there's a lot that needs to be done before we can come with the full facts on that. On the actual figure in terms of the shortage, let me just check my file and come back to you.
Okay, thank you very much, Mr. Maposa. I think you did justice to that question. For most of this information that is still in early stages, we can't do much about it. So now we go to you, Daniel Arap from CGTN, to go live with your question.
Well, thank you very much. My question go out to Dr. Moeti. You have a couple of questions as well. The first one is, what are some of the reasons for poor vaccine rollout in Africa? And number two, some countries are seeking to extend Covishield self-life from 6 months to 9 months from its manufacturing date. What is WHO's recommendation on this? The United States has, of course, now backed the patent waiver for COVID-19 vaccine manufacturing. Now, how do you see this helping African countries in other poor nations? And does WHO consider this vaccine patent issue the solution to Africa's COVID-19 vaccine shortfall or shortage? And finally, the Indian COVID-19 variant is now in Africa. Now, are vaccines being administered in African countries capable of defending against the Indian variant? And how different are the symptoms of this variant? Thank you.
Okay, thank you. That's 4 or 5 questions. I'll start with the one on the reasons for, so what are the factors in the delays in administering the vaccines in some of the African countries? I mean, if I may start on the positive side, what are the things that have allowed countries like Ghana, Rwanda, Botswana, and some others to really be able to fairly quickly deliver the vaccines? First, they engaged in very meticulous micro planning. So it's really necessary to quantify and plan in detail right down to the local level, the vaccine delivery, the targeted population, how many, and then what is needed in various ways, the cold chain, the transportation, the people who are going to deliver the vaccines, the training of the people in order to make things work better. And then secondly, several countries actually tried this out. They carried out a simulation to see, to test what could be some of the obstacles that you may not have thought about that you then identify as you are trying out, simulating, actually carrying out such a campaign. We need to remember, African countries are very used to carrying out vaccine campaigns for under 5 children. Here we're looking at a very different ball game. And then frankly, there are some countries that actually need to mobilize the financial resources to run this operation. And here I think there is more effort to be made. I'm very pleased we were provided some information by our colleagues from the World Bank that there are quite a lot of countries that are in the pipeline that are currently in discussion with the World Bank about acquiring financing. We are aware that the World Bank has offered about $12 billion of financing to enable African countries to acquire vaccines and also to deliver vaccines. And quite a few are in discussions in the pipeline. So the situation of the resources will emerge. Then there is a need to identify very clearly the populations that are going to be the priority groups targeted initially for vaccination, and a need to list these, identify these, pre-register people so that when the vaccine arrives, when it's time for them to be vaccinated, you then don't delay getting the people to come forward. And then very importantly, in some countries, there is vaccine hesitancy. There's a lot of false information circulating around about vaccines. So it is very important to engage right from the beginning in communication campaigns, which really simplify and translate information in ways that people can understand it, for them to understand, first of all, that the vaccine is for their own good, why they are in the priority group. And it's important also to track the kind of exchanges of false information, fake news that discourage people, so that these are addressed. And I just want to emphasize, this needs to be done in simple language that people understand. This needs to be carried through trusted informants that people will believe and that people will trust. And therefore it requires some investment, engagement with those kinds of groups. Then secondly, you asked the question about the expiry date of particularly the AZ vaccine produced by the Serum Institute of India. I mean, just to say that these are newly produced vaccines. So there is the data in terms of their efficacy, how long it lasts for, the ability to trigger the immune response that's required by a vaccine, is being gathered as we go along, as time moves on. And what the Serum Institute of India has done is to extend by 3 months the expiry date of the vaccines that had already been delivered. WHO continues to analyze this data in order to give our own opinion from the WHO experts that are looking at this. And we are advising countries to, first of all, use as quickly as possible the vaccines that are already availed. And then secondly, to store the vaccines, not to throw them away, because we emphasize again, this is a new vaccine. Information about it is emerging. We need every single dose of vaccines that we can get. And we would like to advise to keep the doses and then update the information in terms of the efficacy data. The patent waiver, I think Tabani already responded to that question, really. Is it a solution? It's a very important part of the solution. But as Tabani explained, there are other things that are needed as well in order then to make this a real opportunity to expand quickly and to diversify production of these of the vaccines. The ingredients that go into making the vaccines also have to be produced. The quantities of these need to be expanded. The question was asked about the capacity to actually produce. That needs to be established, meaning there needs to be partnership between the governments, investment in that capacity by the companies concerned, agreements with them, and all sorts of information in terms of the quality of the vaccines that are going to be produced. The regulatory work for expanding those sites of production need to be done. And then, of course, very importantly, then the capacity of WHO to carry out on behalf of many countries that don't have their own capacity to do that, the inspections of the production facilities, if you like, so that we can issue emergency use listing. That's all part of the package of what needs to happen. Yes, and then finally, it is a concern that the Indian variant is circulating in Africa. Sorry, the variant first detected in India, let's be accurate in our description, has been detected in several countries in Africa. That is always a concern because there is a fear that it may be more transmissible than the other variants that are circulating in our context. So there is a need to be even more vigilant while the issue of the vaccine efficacy in relation to this variant is studied. That will only come into play when countries now need to decide which is the other vaccine that they're going to be using. Certainly, the vaccine that is being produced for the COVAX facility in India is what's going to be to be available in African countries. So I think what is going to be done with this vaccine, there'll be real data from the Indian experience of rolling out this vaccine in relation to this variant. Thank you.
And how different are the symptoms for this variant in India?
No, the symptoms are no different. I think, you know, the clinical picture of COVID-19 does not vary with variants. I think what varies perhaps severity of similar symptoms, and then of course what also varies is how transmissible the virus is.
Thank you very much, Dr. Maweti. Dear journalists, really we know that we'd want to provide as much information as possible, especially for your media houses that you're writing for or presenting broadcast. But please note that we would entertain one question per journalist for purpose. We have a lot of questions that we need to handle. So the next question is for you, Dr. Richard Mihigo. Before I go to Dr. Richard Mihigo, I would like to let the journalists know that we also have Dr. Nixie Gumede, our regional virologist in the WHO Region Office for Africa, that will answer all your questions regarding variants. So Dr. Richard Mihigo, the question is from Maggie Fick from Reuters. Any comment please on the spike in cases in Seychelles where a high percentage of the population has received the Sinopharm vaccine?
Okay, thank you, Fiona, and thank you for the question for the journalist. Indeed, we are very carefully following the situation in Seychelles. We must say that Seychelles has been one of the countries that have managed to roll out quite very efficiently the vaccine, being the first dose, and close to 50% of the population have already received 2 doses of the vaccine. But we need also to mention that until everybody is protected, there is no reason why the disease will not continue in the country. So I think that is a very good illustration on how important it is to continue to vaccinate people. But I think we are going to continue to assess the progress in terms of the data that are coming in Seychelles, and our teams are already looking at the patterns and the characteristics of the people who have been tested positive, to look if they've been vaccinated or not, and then to come up with a true picture on the situation that is going on in Seychelles. So we'll be able to provide additional clarification in the next conferences. But the message that we would like to continue to convey is that we need to continue to immunize as many people as possible. And it has been proven that in countries where a vast majority of people have been covered, like in Israel, we have now seen in the US, we can see a real impact on disease transmission. Over.
Thank you, Dr. Mihigo. We have the next question for you, Mr. Maposa, from Paul Adepoju from Devex. He says COVAX facility aims to improve vaccine equity, but among the countries where COVAX is helping to access vaccines, people in crisis zones are largely ignored. What hope through COVAX is available for individuals in the region, considering without widespread access, herd immunity is threatened? But as you answer that, I would also like you to weigh in on this Seychelles issue, because I know Gavi has been following this up. Over.
Thank you very much. And maybe first is to pick up the first question that I promised that I'll come back on the shortfall. I've checked my notes. I wanted to make sure that I give the right information. What was supposed to have been delivered to us by SII is 40 million for March, 50 million for April, and 50 million for May. And we have not had any of those deliveries met. So in total, 140 million that has not made its way to a number of countries. Then on the DEVEX question specifically, I think that the COVAX facility has established a humanitarian buffer, which specifically is trying to reach to marginalized communities that are in hard to reach places. But it is also important, as I talk about this, to emphasize that we have been encouraging populations to be reached through the mainstream ways, which is through the governments. And so the main efforts of advocacy here are to make sure that they are included. But we understand that this is a challenge that comes not just from whether the government wants to include them, but from those groups in particular. Some of them sometimes may not have documentation in the countries where they may be, and they may not feel comfortable to come forward. And so a humanitarian buffer has been established, and it is going to be active and to be weighing in. The Seychelles situation, yes, I think Dr. Mihiko has responded comprehensively to that. I probably don't have much to add. I think I did see a question on the chat that referred to does WHO and Gavi have a different position on the second dose? No, I think sometimes there's something that is probably not understood. Gavi, the Vaccine Alliance, has WHO as part of it, and we work in tandem and together. The prioritization of the second dose remains an important one. I think what Dr. Moeti meant was that for those doses that are already in countries, we are trying to make sure that they reach as much of a population as they can, while we work hard to make sure that the second doses arrive on time, at least within the recommended period between those vaccines. Thank you very much, Fiona. Back to you.
Okay, thank you very much, Mr. Maposa. So the next question is from Sho Beppu, a correspondent for the Joburg Bureau of NHK Japan Broadcasting Corporation, and says, I would like to ask a question to Dr. Moeti. What is WHO's message to some African countries who do not have any vaccine rollouts, namely Burundi?
Yes, thank you very much. As I've said on several occasions, we are encouraging all countries to prepare and take action to vaccinate their populations. And we have indicated that we, as well as our partners, UNICEF, others, of course, the COVAX facility, partners like Gavi, the Vaccine Alliance, are absolutely ready to support such countries. We continue with our country offices to provide all the information needed to support the decision-making of countries. So for example, we are providing constantly information about those vaccines that have been issued with an emergency use listing by WHO, so that governments can be assured that the work has been done to ensure that these vaccines are efficacious and they are safe for their populations. So our message is to indicate that it is important to protect the population. It's a way of protecting the economy in countries, but of course, and we are at the disposal of countries to provide advice, support, work with our partners to procure the vaccines, help them navigate being a member of such platforms as COVAX, and we simply await the decisions of the governments to go forward.
All right, thank you about that. Thanks for all the clarifications we are having. The next question is for Dr. Nixie Gumede. It's about variants and comes from Tobeka from the Daily News newspaper. There are concerns over the variant dominant in India reaching other countries, including South Africa. Has the B1617 variant reached Africa yet? And if so, which are some of the countries where it has been detected?
Okay. Thank you so much, Fiona. And that's quite a very good question. It has been flooding into WHO. If we can give the audience some latest information regarding the variant that was first identified in India. Yes, for your information, it has been reported in some of the African countries. So the first one was the one that reported to us over the weekend, that was Uganda, of which one case was confirmed as a case of a variant of a B1617. And then lately, we are still sort of like making a follow-up with Kenya, because yesterday or day before yesterday, we were informed of about 5 cases that are still associated with the B1617, which is a variant originated from India. So that is, WHO is really making a strong follow-up for the 2 countries to try to give support as much as we can. Over to you, Fiona.
Thanks, Dr. Gumede. So the next question comes back to you, Mr. Maposa, from Katarina Hoji from Bloomberg News. How will you prioritize countries that have signed up to COVAX but have yet to receive doses in Africa, like Chad, Burkina Faso, Central African Republic, among others?
As I said, in terms of the order of priority, it would be to make sure that when we come to the next phase, those countries that are due for the second dose are given the second dose as soon as possible, so that we get the full strength of the vaccines. Then the next in line will be those countries that are ready to receive the vaccines from a readiness perspective and have not yet received, while we continue to work with those that may not be ready to make sure that they get to that space of readiness.
Great. Now to you, Dr. Ngoyi Nsenga. And this question is coming to you, talking about the Indian catastrophe. What can be done to avoid a crisis like India is facing? And are there lessons learned from India that Africa can put into place? Dr. Ngoyi, and that's from ABC News.
Thank you, Fiona, and thank you to the journalist who has asked that question. I think in the introduction, Dr. Mweti has alluded a little bit to that question in terms of what lesson can be learned from what happened to India. First of all, I can say that two sets of lessons learned. The first one is about the drivers. What make the India to be where we are today? What happened? In terms of the drivers, at least from what we're exchanging and discussing with colleagues in Southeast Asian region, is that there are a couple of drivers, including mass gathering related to elections, but also including some kind of fatigue and some kind of relax in terms of adherence to public health measures. And those are the same drivers that we are seeing now in Africa region or in a number of countries. But at the same time, if we take some of those drivers, we have seen that, for instance, in Africa or African countries that held election last year, we didn't see the same kind of pattern. So the African pandemic, again, it has kind of a little bit atypical trajectory in Africa. But still, those drivers remain. And as I was saying, I think last week, there is no reason to believe that those very drivers cannot drive to the situation now we're seeing in India. The second set of lessons that we can learn from India is the response, how the country is responding and what happened, or what you are saying, is it the result of preparedness or some gap in terms of preparedness and response? Those are the lessons, especially, again, Dr. Mweti alluded to that, especially in terms of care or intensive care. Thus, unfortunately, in many of our African countries, the capacity is still very inadequate. So based on that, this is where we are now building on our action in terms of helping countries. The first is, let us first of all avoid to have as huge, large scale transmission as we are seeing it in India. And this is by adhering to public health measures. There's no other way. Of course, we wish we had vaccine in Africa, but at this point, we are not yet at the level of expecting to significantly impact the transmission with the level of vaccination that we are seeing in our countries. That one. Then two, we absolutely, again, Dr. Moeti said it, we're urging countries to not only reassess the situation of intensive care unit, but also to, again, make those units ready. We know that some of the investment are significant, and we cannot expect countries overnight to make those investments, for instance, in terms of having the plant for oxygen plant, but still, what are the alternatives? So countries has to assess their context and make preparedness or readiness in connection to their level of readiness. And this is where we are working with countries in terms of trying to make ready these countries in case the situation or the resurgence that we are seeing in Asia is also happening in some of our countries.
Thanks again, Moeti. Ngo. It looks like we are back to where we were at the beginning of last year, preparedness mode. So this now goes to Dr. Mihigo. The Democratic Republic of Congo has relatively low COVID-19 cases and deaths, but testing is still quite low. Are the numbers feared to be much higher? And what's the status of the vaccine rollout there? The country returning 1.3 million doses after deciding not to use them. Are you concerned about vaccine hesitancy in the DRC?
Okay, thank you very much, Fiona. Very much, I believe that, as we have heard from Dr. Ngoy, we have seen a very atypical situation in terms of the outbreak trajectory in many of our countries. And we've already said this in many of the past briefing with the media, though the testing level in many countries is low, I think many countries have not seen the level of number of cases that have crashing the system in those countries. However, I believe that working with our country office on the ground in Kinshasa, our WHO country office there provides the necessary support to the government in terms of this reassessment of the public health measures that Dr. Ngoy have mentioned, strengthening the preparedness in case there is a surge in number of cases. So I think the level of alerts, the level of surveillance, the level of preparedness have been heightened with the support of the partners on the ground. And we hope that by continuing that way, we may not see any major surge. Now, coming back to the issue of vaccination, it's true that some of the doses that were allocated to DRC, 1.3 million, have been reassigned to other 5 countries in the region. And one of the reasons was the country inability to roll out this vaccine as quickly as possible before the expiry date arrive there. So I think this is also due to the fact that there was a long pause beginning of March when the issue around the safety concern of AZ vaccine were raised. And I think that couldn't allow the country to fully use all the doses. Now, in terms of vaccine hesitancy, clearly, we have seen a surge in terms of vaccine hesitancy, particularly in urban areas where there is a high penetration of social media. And this is something that we are working on quite aggressively to support countries, including DRC, on how, through the Infodemic Alliance that has been created by WHO and other partner, we can provide the right information so that we can educate people to adhere to the vaccination. So in conclusion, I think we are watching the situation in DRC quite very carefully. The remaining of the doses that are being currently administered in the country, we are working closely with them. They've now started even to ship the vaccine in the provinces, I think, which is a very good move to decentralize the vaccines at the peripheral level and not in Kinshasa alone. And we hope that this different strategy will help not only to use the available, but at least to remove some of the bottlenecks that currently exist in terms of vaccine hesitancy, so that the next phase of the rollout could happen more smoothly.
Okay, now the next question is from you, Bart Mensing of ZF. Please go live with your question.
Yes, thanks very much. We have 3 questions. One was partly answered, but I want to ask it again. Like, to which extent is vaccine hesitancy actually affecting the vaccine campaigns on the African continent at the moment? Then our second question is, how could a change in the patent regulations actually change the supply situation for vaccines for African countries, and how fast? And do you have the feeling that now, day by day, the situation is getting more unfair because countries like Germany, the UK, the US are actually getting ahead with their campaigns while there's no supply for African countries at the moment? Thanks.
Okay, I'll give that to you, Dr. Moeti, and also ask Mr. Maposa to weigh in.
Okay, thank you. So first of all, what is the extent of vaccine hesitancy in African countries? I think it's very variable from one country to another, and even from one place in a country to another. You know, there are countries where we understood up to 50 or even 60% of people were not keen to be vaccinated, and others where most of the population is willing to be vaccinated. So it's very variable. We certainly have seen in countries like Cameroon, for example, and there was mention of the DRC, that in some places that it is quite significant. So that this is something that needs to be addressed very comprehensively, very strategically. And just to repeat what I'd said earlier, in many different ways, we need to understand what it is that people are believing, thinking, fearing, or not understanding, so that the communication with people can be done much more effectively. You know, I think it's one thing to have political leaders speaking on the television, telling people broadly what needs to be done. It's quite another to have somebody understand as a person, an individual in a particular context, why the story that they've been told is not true. Why should they believe it? I think we need to really look at that level of detail. We should carry out surveys, support the countries to carry out surveys to reach this level of understanding. And of course, we know that it's not only people's fears. There are groups, including international groups, that are fueling this anti-vaccine tendency, which has not been severe in African countries in the past. There is a distinct additional movement from some anti-vaxxers in some Western countries that's taking the advantage of all the concerns about variants, concerned about the adverse effects of vaccines. We need to address all of this. And I just like to repeat again, it has to be person to person, trusted persons, based on understanding and knowing what it is that people think, feel, fear. And then secondly, how can patent waivers support countries? I think that question has already been answered. It's a first step. It is part of expanding the possibility quickly of the pharmaceutical companies that owns the intellectual property, working with other partners, with manufacturers, so that they can then manufacture not in the facility that's owned by the pharmaceutical companies that have developed or that are controlled by them. So it's diversifying the manufacturing points. And if that is going to happen, it means that there needs to be broader sharing of information about information about the product that would normally be protected as part of the patent by the owner so that they are in control of this information, and they control the production, and therefore control also the resourcing and the earning of profits from what they invested in as intellectual property. So it can help, because what is needed is to rapidly expand, rapidly diversify the sites of production. And again, it's not the only thing that's required, but it is necessary in terms of the urgency of the situation now. And just linked to your last question about the growing unfairness. So we have seen that countries that have the resources, the capacity to produce, are really progressing very, very quickly. And if we compare where African countries are now, we've seen that partly due to the situation in India, where we have to appreciate another developing country being the world's factory for these vaccines, particularly for poor countries. They're facing now a very difficult situation, and the African region is lagging behind or being left even further behind. And indeed, so the inequity is growing. That's why we are adding our voices, that those countries that are now vaccinating people over the age of 16, while African countries have yet to finish vaccinating their healthcare workers and elderly people with comorbidities who are at risk of severe disease, that you know, the donations, which we appreciate very much, the sooner they could come, in the greater volumes that they could come, then the more progress we'd be making to close the gap.
Great, Dr. Moeti. Mr. Aposa, do you have anything to add on to this?
Dr. Moeti has covered it so eloquently. I wouldn't add anything. Thank you.
Great. The next question now, the floor is to you, Elizabeth Merab from Daily Nation, to go live. Again, a reminder, one question, please.
Yeah, thank you, Fiona. So for me, I'm seeking a clarification. Maybe the RD has already spoken on this, but last week, WHO and Africa CDC advised African countries to act now to avoid being in a similar situation as India. That was before any case of the B1617 variant was detected in any country. Today, we are talking about Kenya and Uganda having reported the first cases. Does this heighten concerns for the continent? And if so, what decisive advices are you giving to governments?
Okay, I think we're giving advice to governments to reestablish or sustain, at the very least, look at the situation and do everything possible to prevent an upward spike. As I already said, we are seeing increases happening in countries where this variant is not circulating. So I think we need to be very clear. We don't just fear the variant from India. We would like to prevent a resurgence and third waves in all countries based to whatever virus is circulating there. Because what has given rise, and I think Ngoy described quite eloquently and in a lot of detail, what is driving some of the upward spikes is to do with the public health measures and the degree to which they are being practiced or not. And we know there's fatigue on the part of the population. In the city where I live, I go to the supermarkets every Saturday to do a kind of visual survey of how many people are wearing their masks properly. And I've noticed that the fatigue is visible. More and more people are not even wearing a mask at all in public. I was hoping personally that being without a mask in public would be like walking around not dressed in public. We should be horrified to see this. Increasingly, it's being accepted as normal. This is not okay. Distance keeping is also becoming a difficulty. People are tired. We need to re-inject the energy in this and support people to sustain this, whatever variant is circulating. And then absolutely, we need to avoid mass gatherings around elections. We need to learn what was done by African countries so that we did not have the upsurges, and we did in a couple of countries, the peaks, the very dramatic situation that we're seeing in India linked to elections. We know that some governments did really try to maintain some sort of distancing. And we know when there were elections in others, when that did not happen, there were surges in cases. There were very important people who were involved in elections who actually died in those situations. And then we have to make sure as well, religious practices, those activities, very human activities that tend to push us to be together are managed. And then, as we've said before, those lockdown measures that governments have imposed are now progressively relaxing, need to be looked at again, looking at the data locally. If we're seeing an uptick, then it might be that the government needs to finally intervene and limit people's movements. So those are things that need to be taken into account constantly. And as we said, although we have a plateau overall in the continent, we are seeing in almost 10 countries an upsurge, and we are concerned about the Southern African winter coming in, with South Africa as a country that has had the worst situation on the continent. That again, that level of population support for their role and ensuring that mass gatherings do not happen really needs to be heightened by the governments.
Okay, so we are winding up. We still have so many questions that came to us prior to this press briefing, but also others that we are getting. So I'll bundle up one question that keeps coming up, and I'll give it to you, Mr. Maposa, and it's about COVID vaccine passports for Africans to travel to the rest of the world. At the higher level where you sit at the COVAX facility with WHO and other organizations, what is your take on the need for COVID vaccine passports?
Thank you very much. We do not believe that vaccine passports should be the subject at the center when we really haven't vaccinated so many people. The subject at hand is how do we supply vaccines and how do we get them to people who need them as fast as is possible. So vaccine passports are not our priority right now. The priority is to get people vaccinated.
Excellent, excellent answer. And finally, the last question goes to you, Dr. Nsenga. What are the results of the second meeting of the Regional Expert Advisory Committee on Traditional Medicines for COVID-19, which took place in March 2021 to review the progress made in implementing recommendations of the first meeting and its roadmap? Quite a mouthful.
Yeah, thank you very much, Fiona. Thank you again for the question. Of course, we are very much in contact with colleagues dealing with traditional medicine in the regional office. For as far as I know a little bit of the meeting, there was some kind of very interesting decision. For instance, I know that Nigeria as a country has decided or agreed to give kind of a temporary authorization to some herbal medicines. But however, I'll insist on what we are doing together with our colleague who is the focal person for traditional medicine in Africa. Because again, this has led to kind of a discussion, controversy in Africa, some questioning why Africa is not using herbal medicine, or some thinking WHO is kind of downplaying traditional medicine role in dealing with COVID. But we think science is universal. There is no black science or science for black or science for Africa and science for Europe. Science is universal. And of course, medicine, including some herbal medicine, all used as traditional medicine, for it to be validated as a medicine for any disease, not only for COVID, it has to go through the process. So to support our countries and to help them in terms of exploring, I won't say studying, exploring some of the traditional medicine effect on COVID, we are supporting countries in building capacity in conducting clinical trials. That's the only way, that's the best way to go. And that's the universal way to go. So we have, for instance, very recently, again, in collaboration with our colleague dealing with traditional medicine in the regional office, hired a consultant who will be main role will be building capacity in terms of best clinical practice and good clinical practice dealing, of course, we'll be working with the colleague at country level and the national medicine regulations agencies in terms of building those capacity, and of course working in collaboration with the traditional medicine agencies or whatever that can be institution at country level to at least build capacity so that we start talking about science with traditional medicine in Africa. I think this is what, as a team dealing with COVID and Afro, that's what we are doing, trying to help our traditional medicine to get out of a kind of ghetto, but be also admitted in the general science realm of dealing with COVID. Thank you, Fiona.
Okay, so we still have lots and lots of questions, and we shall run a little bit longer than usual because I'm told the bulk of questions is actually a lot. So the next question is from Nita Balia from Reuters, and this is to you, Richard. If people do not get their second dose within the 12-week time frame period, is there a risk that countries will have to restart and revaccinate them with the first dose again? Dr. Nihigo?
I think the connection was not good.
Okay, so the question is, if people do not get vaccinated, do not get a second dose within the 12-week time frame, is there a risk that countries will have to restart the vaccination and start again from first dose?
Oh, okay. No, thank you, Fiona, for that. No, absolutely not. I think the proposed current schedule of vaccination of 2 doses that have been recommended by WHO came up after extensive really looked at the data and what is the maximum benefit that people can get after receiving 2 doses apart with 12 weeks apart. There are even current studies that are going on in countries where this 2-dose interval has been pushed up to 16 weeks. So there is no need to restart for the first dose after that interval. We just hope, as we've heard since the beginning of this conference by the colleague from Gavi, that as soon as the supply become available, country will proceed with the administration of the second dose, because record has been kept for those who have been receiving first dose. So there's no risk to restart from fresh for those who have been already receiving 1 dose.
Okay, great. More and more information coming up as studies go on, like it was mentioned. So as we wrap up now, we have a final question from Vincent. And then these are from, sorry, I can't see the journalists, but the question is, how long would it take African countries to start producing the COVID vaccines? And what is the most urgent need right now regarding vaccinations on the continent? These are for you, Dr. Moeti.
Yes, thank you. I think it's difficult for me to say how long it'll take African countries to be able to start producing vaccines, but there's certainly intensive discussion going on. There was a summit the other day at a very high level to talk about, among other things, producing vaccines locally. There are some institutions that have the capacity to produce vaccine. There are vaccine producing entities in some of the North African countries, in Morocco, in Algeria, in Senegal. There's the Pasteur Institute, which is able to produce some vaccines. In South Africa, there is vaccine producing capacity. I think what is needed now is really the additional investment in the capacity, with the expectation then that all the other steps will be taken, the sharing of the patent waivers, the sharing of information, technical details about the vaccine and so forth. There is certainly a very intense discussion and process ongoing, supported at the highest political level, supported technically, including with the involvement of organizations like WHO, and with the participation of the private sector, other partners like Gavi. I think you need a partnership among all of these in order to be able to speed up the production on the African continent.
Okay, so if only we had the luxury of extra hours and much more time would answer all your questions, journalists. But you know that we always also get back to you in writing once you send us your question. So we are coming to the end of this virtual press conference. Let us turn to our two panelists to hear any final messages, giving them a minute each. And I'll start with you, Mr. Tabani Makosa.
Thank you very much, Fiona. I think that the first one is that the situation in India is of grave concern, and it's one that we must guard against from happening in Africa. The second one is that the news from the US is very welcome news at this particular point. It means that the supply can increase and improve. But I think, as Dr. Moeti said as well, it means that the price point of vaccines may remain at an affordable level. Then the third point, for those countries that have received vaccines, it is important for the uptake to increase. Without that uptake increasing, it seems like we are contradicting ourselves. Here we are talking about the need for vaccines in Africa, and yet we have African countries that have vaccines that are quite a handful. They are not much, if I were to say it, but they have not been absorbed. And so it is very difficult in my own mind to reconcile how do we work this. If we suddenly had a lot of vaccines, what then would happen? Do we risk to have a situations where vaccines will be wasted? I will hope that after all these efforts that we've been putting forward, we don't live to see a day where vaccines are wasted. So we are in all this together. And Dr. Moeti said something that left me chuckling here. But indeed, if anyone is still walking out there without a mask, it is like walking out of your house naked, and it is horrifying. And we need to stand up to the virus. Thank you.
Thank you indeed. Dr. Moeti.
First, I'd like to thank Tabani very much for having joined us and provided this very enriching information to our colleagues, the journalists. I mean, just by ending, I also would like to say that the situation in India doesn't inevitably have to happen in Africa. We can avoid it. We know what to do to avoid it. We've done it before on the continent and surprised everyone with an evolution of a situation that was not so bad. And I'm not talking here about going back to the lockdowns, but we have experience now as African people of implementing these measures. And our governments have experience and partners in supporting people to implement these measures. So if the governments play their part in terms of the policies, the strategies, discourage, don't allow mass gatherings, leaders of various entities in life, the religious leaders, political leaders, don't let people gather, individuals in families play their part, I think we can avoid what's happening in India. And then as far as the vaccines are concerned, let's use the delay, which is very unfortunate, as an opportunity to really sharpen our readiness and speed up and improve on the vaccines that we already have on the continent. So I will be asking my staff in the countries to sit down with the governments and analyze in a lot of detail what it is that has slowed down the use of these vaccines that are so precious on the continent. And we'll do our best with our partners in the UN and others to support the countries to speed up. One thing that is needed is financing of these campaigns. And I'd like to add, although Tabani didn't say, that we also are hoping our member states will play their part in mobilizing the funding that's needed for the COVAX facility, because we still have gaps there in funding. And I think that together with solidarity and just to thank those countries that have declared their willingness to share their doses, we are expecting that to be delivered as quickly as possible. And then in the latter part of the year, we expect more volumes to be available. Let's be ready and let's be able to deliver them into the arms of people. Thank you very much.
Thank you. And to our dear journalists, it has been really great having you again, and we look forward to having you again on the next press conferences that we shall have. Remember that we still have a number of questions that are coming in French, but mostly about vaccines. So Dr. Richard Mihigo will stay with you, the Francophone journalist, to answer your questions. Have a good day. Do not relent. Please keep safe. This will also come to an end. Over.
Oui, bonjour à tous. Bonjour donc pour cette deuxième partie de la conférence de presse qui se fera en français avec le docteur Richard Mihigo, qui est le coordinateur de la vaccination et de la mise au point des vaccins au bureau régional de l'OMS pour l'Afrique. J'espère que le docteur Mihigo est toujours avec nous. Nous avons plusieurs questions qui concernent principalement les vaccins. La première question vient de RFI, de Christina Okello. C'est à propos de l'annonce de l'Union européenne. Bonjour, Dr Richard Mihigo. C'est donc à propos de l'annonce de l'Union européenne qui affirme être prête à discuter d'une levée des brevets sur les vaccins contre la Covid. Qu'est-ce que ça voudrait dire concrètement pour l'Afrique? Et cela permettrait-il aux pays africains de pouvoir fabriquer leur propre générique? Dr Mihigo, c'est à vous.
Merci beaucoup, François. J'étais légèrement déconnecté il y a quelques minutes.
Vous voulez, je vais répéter la question, pas de problème. C'est une question qui nous vient de Christina Okello de RFI à propos de l'annonce de l'Union européenne qui affirme être prêt à discuter d'une levée des brevets sur les vaccins contre la Covid. Qu'est-ce que cela impliquerait pour l'Afrique et cela permettrait-il aux pays africains de pouvoir fabriquer leur propre générique?
Ok, merci beaucoup. Non, nous avons également appris ce matin cette bonne nouvelle de l'Union européenne qui, à l'instar de ce qui a été annoncé hier par les États-Unis, de considérer effectivement la levée de ce brevet pour la fabrication des vaccins. Donc, je pense que nous avons maintenant une certaine convergence de points de vue, d'approche de la part des États-Unis, mais de l'Union européenne, l'Union pharmaceutique mondiale. Donc, je pense que comme dit depuis ce matin, c'est exactement une très, très bonne nouvelle pour l'Afrique. Alors, quelles sont les... Je pense que il faudra absolument prendre le temps d'utiliser ces opportunités, effectivement, pour accélérer le processus de transfert des technologies, accélérer le processus de validation au niveau des pays. Et certains pays en Afrique qui sont déjà en première ligne, surtout après la conférence qui avait été organisée il y a quelques semaines par l'Union africaine, offrent effectivement une certaine opportunité pour avancer très rapidement. C'est le cas, par exemple, de l'Institut Pasteur, qui avait déjà annoncé la potentialité d'étendre sa capacité de production locale au Sénégal. Mais nous savons également que certains pays du Maghreb sont également dans cette position, ou l'Afrique du Sud. Donc, je crois que c'est des très, très bonnes nouvelles que nous avons reçues ces 2 derniers jours. Mais il faudra voir comment cela va être réellement transformé en action concrète sur le terrain. Et l'OMS, bien entendu, est prêt à travailler avec ces pays pour accélérer ce processus de transfert de technologies.
Merci beaucoup pour les clarifications. La question suivante nous est posée par Youssoufa Miné de Dakar Actu au Sénégal. C'est une question sur le variant qui a été détecté en Inde. La semaine dernière, l'OMS annonçait que ce variant a été détecté dans 17 autres pays. Savez-vous quels sont ces 17 pays et surtout dans quel pays africain ce variant est-il présent? Docteur Migo, avez-vous entendu ma question?
Ok, j'espère. Oui, j'espère que j'ai tout très bien compris, bien que la ligne soit un peu. Effectivement, certains pays au niveau du continent africain ont déjà commencé à détecter le variant qui a été principalement découvert en Inde, le B1.1.67. Nous avons 3 pays déjà qui ont déjà confirmé la présence de ces variants au niveau du continent africain. L'Ouganda depuis la semaine passée, le Kenya, où un cas a été détecté en Ouganda, ont reçu des résultats de séquençage où 5 cas ont été détectés au Kenya, mais également le Maroc a détecté quelques cas. Donc, il n'est pas du tout étonnant à ce que d'autres pays d'ailleurs puissent avoir déjà la présence de ce variant en circulation sur leur sol. Donc, pour ne pas effectivement répéter ce qui s'est passé dans le passé, je crois que premièrement, nous continuerons malheureusement, si les gens ne sont pas vaccinés, si le virus continue à voir l'émergence de ces nouveaux variants, même d'autres qui vont certainement être originaires de notre propre continent. Il faudra absolument renforcer les mesures barrières de prévention au niveau du transport, au niveau de mass gathering. Bientôt, nous allons avoir la fin du Ramadan, la semaine prochaine, qui va certainement créer des mouvements de foule où des gens doivent se réunir. Je crois que c'est le moment peut-être de lancer un appel à tous ces pays où les fêtes de Ramadan vont avoir lieu la semaine prochaine, qu'elles puissent se passer, bien entendu, dans cette ferveur religieuse, mais tout en respectant les mesures barrières. Et enfin, la seule façon réellement sur le long terme d'éviter cela, c'est effectivement de continuer à vacciner les gens, et de se faire vacciner de manière à ne pas donner l'occasion au virus de continuer à circuler, à muter et à se transformer dans des variants qui peuvent devenir virulents et se propager très rapidement.
Merci beaucoup. La question suivante était du journal Le Monde et concernait le Ramadan. Vous venez d'y répondre. Je vais donc passer à notre dernière question qui vient du Togo, du magazine Afrique Rendez-vous, qui concerne le retard en approvisionnement des pays africains en vaccins contre la Covid-19. Beaucoup pointent du doigt des conditions difficiles d'accès des pays africains au financement de la Banque mondiale. Qu'en est-il exactement ? Est-ce que cela ne risque pas d'affecter réellement le programme de vaccination dans les pays?
Ok, peut-être pour revenir un peu sur la question du Ramadan. Au tout début du Ramadan, l'OMS avait publié des directives pour aider les pays qui célèbrent le Ramadan à comment est-ce que de manière sereine, mais également dans la mesure stricte d'hygiène, cela puisse se passer. Nous sommes en train de travailler également pour cette fois-ci publier des nouveaux guidelines pour voir comment les fêtes du Ramadan puissent se passer dans de bonnes conditions, comme nous l'avons fait par exemple en fin d'année avec les fêtes de Noël. Donc nous avons eu plutôt quelque chose de pas très satisfaisant autour de fêtes de fin d'année et de fêtes de Noël. C'est pourquoi nous sommes extrêmement prudents pour que les directives ou les guidances que nous avons émises en tout début du Ramadan puissent également être revues, publiées pour faciliter une sortie de la fin du mois de carême pour nos frères musulmans dans des conditions de santé optimales. Alors, en ce qui concerne les retards d'approvisionnement, ils sont de plusieurs ordres, hein, les retards d'approvisionnement. Nous avons entendu ce matin de la part de nos collègues de Gavi que sur 140 millions de doses qui devraient être livrées au niveau des pays, 40 millions au mois de mars, 50 au mois d'avril, 50 au mois de mai. Malheureusement, ces 140 millions de doses qui devaient venir du Serum Institute of India n'ont pas pu être livrées au niveau des pays à cause de la situation malheureuse que nous connaissons tous qui se passe au niveau de l'Inde. Mais de l'autre côté, il est vrai que bien que la plupart des pays espéraient recevoir la majorité au moins jusqu'à ont eu du mal à accéder. Nous avons eu une réunion J'ai été coupé tout à l'heure. Donc, je disais que par rapport au financement additionnel des doses avec les financements mis en place par la Banque mondiale, mais également la Banque africaine d'import et d'export, Afrexim, il est vrai qu'il y a eu un certain nombre de retards pour l'accès à ces facilités financières. Nous avons eu une réunion intéressante avec nos collègues de la Banque mondiale la semaine passée, qui nous ont informés de tous les efforts qui sont mis en place pour le moment pour accélérer l'accès de ces fonds au niveau des pays. Nous avons donc bon espoir que cela va se passer ou s'améliorer dans les jours à venir.
Merci beaucoup, Dr Mihigo, malgré les petites difficultés techniques, mais je pense que votre réponse a été bien entendue par tout le monde. Nous avons fait le tour de nos questions pour cette semaine. Donc, encore une fois, merci énormément à vous. Merci à tous les journalistes qui sont restés pour cette session spéciale en français. Et, nous vous donnons rendez-vous de nouveau la semaine prochaine. Merci beaucoup à tous.
Okay, merci et bonne semaine.